I'm Joyce O'Shaughnessy, the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. The co-occurrence of a new diagnosis of early stage or locally advanced breast cancer with pregnancy, fortunately, is a very rare event. About 2 to 5 out of 100,000 pregnancies will be complicated by a diagnosis of breast cancer, thankfully. The definition of pregnancy associated breast cancer is actually breast cancer during the actual pregnant state or the development of breast cancer within a year after delivery. If a woman delivers her child and is found to have developed breast cancer within a year of that delivery, she is treated as any other woman would be treated, um, outside of pregnancy. And the only caveat is that if a woman is breastfeeding, if she's nursing, then we would want to stop breastfeeding before she is treated with any kind of systemic therapy after delivery. But with regard to a woman who is discovered to have breast cancer during her actual pregnancy, and sometimes women are found to have breast cancer, and then later during treatment of the breast cancer, they're found to be pregnant. That's of considerable concern because if a woman has been receiving cytotoxic agents or endocrine therapies or trastuzumab, pertuzumab for her early stage or locally advanced breast cancer, and she is found to be pregnant, and that means the fetus has been exposed in the first trimester to these carcinogenic agents, then that is a high risk for fetal malformation and fetal death, intrauterine growth retardation, et cetera. So unfortunately, there has to be very serious consideration given to pregnancy termination because of fetal harm from the breast cancer therapy. Thankfully, that's unusual for women to be in the midst of breast cancer treatment and to get pregnant during treatment, although it does happen. Unfortunately, it's very, very important that we tell our women who have childbearing potential that during their treatment for their breast cancer, it's of the utmost importance to avoid pregnancy because of the very high risk of fetal malformation if the fetus is exposed to our breast cancer therapies during the first trimester. What's more common is a woman who is pregnant and is found to have a breast mass that upon evaluation is found to be breast cancer. That's more common. And so let's talk about the diagnosis of breast cancer during pregnancy. I think one thing to say is that it's a very difficult diagnosis because the breasts become enlarged, engorged, and it can be difficult to ascertain a mass versus just the normal changes of the pregnant breast. Nonetheless, I think it's very important for there to be a high index of suspicion and to err on the side of doing an ultrasound to evaluate an area of concern. Certainly any erythema should be evaluated for the potential of an inflammatory breast cancer. Mammography with abdominal shielding is also considered acceptable if need be, but ultrasound also, of course, would be very, very safe. MRIs are not safe during pregnancy with regard to the need for contrast to actually diagnose the breast cancer on MRI. And then, of course, biopsies of the breast are safe. The risk of developing a milk fistula with a biopsy is exceedingly rare, even in the last part of the pregnancy. So it is safe to do a biopsy and to obviously understand what is the subtype of breast cancer. If a woman is diagnosed in the second or third trimester of her pregnancy, she can receive doxorubicin, cyclophosphamide, AC chemotherapy, with or without 5-fluorouracil. And there is actually a large series from the MD Anderson and other centers that have really followed these women prospectively for decades now. And it appears to be quite safe for a woman in the second and third trimester to receive AC or FAC for 4 to 6 to even 8 cycles with the lower dose of doxorubicin that one would receive with FAC, 50 milligrams per meter squared. It's safe to the woman, the mother herself, as well as to her child who was born. The rate of fetal malformations appears to be no higher than one would expect in the general population. And there's a nationwide registry study following these children for a long period of time for later occurrence of malformations, toxicity, heart disease. But so far, it looks quite reassuring that the infants and later the children that are born do well after having been exposed second and third trimester to a chemotherapy. Unfortunately, no therapy that we use to treat breast cancer is safe during the first trimester. One obvious consideration is that, unfortunately, most young women who are pregnant who develop breast cancer develop grade 3, highly proliferative, triple negative breast cancers, or ER positive, HER2 negative breast cancers, or rarely HER2 positive breast cancers. And these are very virulent breast cancers. And the safety of waiting for a full pregnancy if a woman is diagnosed early in her first trimester is a bit of concern. It's a bit problematic. And so that is a really important discussion with the woman about the risks and benefits of waiting in her particular case. Now I will say it is very safe to proceed to surgery, particularly mastectomy and axillary lymph node dissection is very safe. The anesthesia can be associated with intrauterine growth retardation, but that's uncommon. So it is very safe to proceed to surgery in a woman who, for example, is earlier in her pregnancy and wishes to keep the pregnancy. Sentinel lymph node biopsy is generally not encouraged because there are relatively few data with regard to the safety, for example, of technetium-99. There was a series from the Mayo Clinic showing that it appears to be safe, but there's not a lot of data. And with regard to the blue dyes, isosulfan blue can cause rarely anaphylaxis, which has to be considered only about 1%. And methylene blue is contraindicated because it can cause jejunal atresia. So in general, sentinel lymph node could be considered potentially with the use of technetium-99 because the amount of fetal exposure to radiation is less than the 5 centigrade that is recommended be the limit from our national radiation safety guidelines. Nonetheless, I think we would rather avoid that if at all possible. So a mastectomy and axillary lymph node dissection would be, generally speaking, the preferred way to go. It's possible to do a lumpectomy earlier on in the course of pregnancy before the breast becomes very, very engorged and may have more difficulty healing. But in general, mastectomy is probably simpler and is preferred. So that could then get a woman through until she reaches the second trimester, where she could begin AC every 3 weekly, because you want to be able to give the woman enough coverage with the chemotherapy to get her closer to her natural delivery date. There has been some look at the safety of giving filgrastim during chemotherapy. Interestingly, it's not usually necessary because women who are pregnant, interestingly, seem to have less in the way of neutropenia than they would otherwise if they were not pregnant. But there's very little data with regard to PEG filgrastim, so probably not recommended, generally speaking. With regard to dosing of the cytotoxic agents during chemotherapy, most of the series recommend using the woman's actual body weight, which of course will go up as she progresses through her pregnancy, and that appears to be safe. And so then working very closely with the woman's obstetrician to get her as close to her natural date of delivery, looking to see if it's possible to deliver the baby several weeks earlier, in order to then be able to proceed with the rest of the woman's therapy for her breast cancer. It is not safe, unfortunately, to utilize trastuzumab, pertuzumab, or any endocrine therapy during pregnancy. No radiation therapy at all. Those will have to wait until after delivery. There are multiple case series about some safety of docetaxel paclitaxel and carboplatin. So there's a limited amount of data there, but methotrexate, also the CMF regimen, is not safe either. So a limited repertoire therapeutically that we can utilize during pregnancy. And then once a woman delivers, she can finish her staging evaluation and she can finish her standard of care therapies. And fortunately, the outcome for her child appears to be quite favorable, and for the woman herself. This seems to be something that the mother and the fetus, they weather it remarkably well, which is a very definite positive.